Welcome back to this 12 Days in March video podcast edition. This material was delivered during a series of live lectures at the University of Massachusetts Medical School. In this edition, we will focus on the portal circulation and derivatives you will need to know for the USMLE Step One exam.
So this is it. This is the liver. Got it? Portal triad. We got the portal vein with a couple of vessels made up of splenic vein, superior mesenteric vein. Got it. Celiac artery, back in anatomy, used to be my favorite vessel. Now I have to use mnemonics to remember things. That left-hand side, left gastric, common hepatic, splenic. That should all be pretty straightforward to you guys. And we have the bile duct, and what's really big, and we'll spend time talking about the components of bile, that becomes a big topic. So we know that blood flows to the central vein, bile goes to the portal triad. Then the blood gets to the central vein. It's got to get up to the heart via the hepatic vein, IVC, and ultimately the right atrium. And of course, we emphasize that because heart disease is going to be reflected back into the liver. And they like the idea of associating organ systems, liver and the heart. And you know that you have these zones of the liver. And they never say zone 1, 2, 3, but there are the zones. Zone 1, oxygen-rich. Who lives in zone 1? Hepatitis C. It likes oxygen. It's a periportal inflammation. So zone 1 is good. It's got oxygen. Zone 3, not so much oxygen, relatively hypoxic, and that's where the cytochrome P450 systems, the enzyme systems, are located in zone 3. And consequently, when you think about drug toxicities and things like Tylenol toxicity, where are you going to wind up with problems? In the central lobular region. Okay, that's the relevance of the zones. Portal hypertension, you have signs and symptoms from. It doesn't tell you the disease. Lots of diseases cause portal hypertension. And what's common to them is the idea of third space, so edema, ascites. That's easy. That's what's present. What's not present, and this is big, is no JVD, and they're going to come after you repeatedly on the idea, is this from the liver, is this from the heart, where is it from? So portal hypertension, no neck vein distension, no elevation of the central venous pressure. In a patient with portal hypertension, generally speaking, their volume deplete from the third spacing, so you get renal hypoperfusion, an activation of the RAA, and ADH secretion. So hyponatremia may be commonly reported in a patient with cirrhosis and ascites. So that's kind of a spin-off. Why do they have hyponatremia? They're hypoperfusing the kidneys. Portal hypertension, we have third space of fluid. Splenic congestion, so hypersplenism, and I just want to emphasize, I'll say it 20 times. So it's all cell lines. We're really used to thrombocytopenia, but it can be leukopenia and anemia as well. And then, of course, varices. So those are signs and symptoms of portal hypertension, but it doesn't tell us the cause. You get a portal hypertension if you're blocking up the central vein for whatever cause, or the portal vein. But the most common course, of course, is cirrhosis. And, you know, everybody thinks that's a drawing of cirrhosis. He's got to do better than that, but I don't think it's all that bad. It's a pretty good drawing. So again, portal vein thrombosis is great. Hepatic vein thrombosis, I think, is thrilling, but cirrhosis is going to be the most common cause. And again, when they're describing portal hypertension in someone who's high risk for cirrhosis, the answer is cirrhosis. All right, so let's do circulation. All right, so back to, and here's a little, again, overlap in this portal hypertension, ascites, hypersplenism, varices. Portal hypertension, multiple causes. Cirrhosis is only one of the causes, so you have to keep your guard open. All right, so what are the key points about portal hypertension? Again, the liver, dual circulation. So although we see shock liver, dual circulation, you'd say the liver is relatively protected. With prehepatic, so here we are with portal vein thrombosis, and no matter how many times I say it, it's prehepatic, it's before the liver, so you can have signs and symptoms of portal hypertension, but the liver's not involved. So there's no transaminase elevation, bilirubin, it's all fine. It's portal hypertension from the portal vein, but the liver's safe. You have post-hepatic, central vein obstructed, or congestive hepatopathy, central lobular hemorrhagic necrosis from congestive hepatopathy from heart disease. And then, again, portal hypertension from cirrhosis. I'm just going to bring this right home. We're prehepatic, so you can obstruct, and they do, the portal vein or splenic vein. And if you obstruct the splenic vein, you still will wind up with hypersplenism, less so varices, but you can get gastric varices from the small gastric veins. So in this instance, it's going to be portal hypertension, the liver is spared, and with almost all thrombotic states, they're going to give you some predisposing thrombophilic condition that we'll see on the next slide. Let's just start with post-hepatic being, you can have it from heart disease, right heart failure, or, again, the common one for congestive hepatopathy, constricted pericarditis. What causes that? TB, mostly radiation. Again, if you have portal hypertension with JVD, we know that it's coming from the heart. So these are hepatic manifestations of heart disease. The other, post-hepatic Budd-Chiari, hepatic vein thrombosis. And in that instance, anxieties, large tender liver, because the liver capsule acutely distends. And the big ticket item there is always with a thrombophilic disorder. Myeloproliferative, like P. vera, is going to be real common. And again, it's a way for them to take a hematologic malignancy and overlap with another organ. And oral contraceptives for the boards is not about contraception, it's about thrombosis. So the two oral contraceptive issues in the liver are Budd-Chiari, also the issue of a bleeding hepatic adenoma. Hepatic adenomas are hormone dependent as opposed to nodular hyperplasia, which is not. We'll cover that at the end. And the diagnosis is ultrasound, reversal of flow. Alrighty, and here it is again, ultrasound, the blood is flowing the wrong way. And so ultrasound looks at structures, Doppler measures the blood flow, reversal of flow, and that's how you would distinguish the two. Intrahepatic cirrhosis, and not going to beat the portal hypertension to death, but do bear in mind, portal hypertension, hydrostatic edema ascites, but with low albumin, you also have a component of oncotic edema. As far as varices go, I'm sure you guys are spending a lot of time looking at the vascular connections. They ask precious little. They include varices and ask derivative questions about bleeding, or when they include varices, again, they expect you to know that the patient has portal hypertension and or cirrhosis. That's how they use them mostly. I rarely, if ever, see a question is like, oh, what are the connections? I would be familiar at least with the portal esophageal vein, meaning the azygos from the systemic circulation. Same around the hemorrhoids, the superior rectal vein, meaning the middle and inferior rectal vein from the systemic circulation. And again, the way they use it is patient with periumbilical vessel distension, and they want you to know, again, the patient has portal hypertension. But to be familiar, periumbilical meaning the superficial and inferior epigastric veins. Okay, so I'd be familiar with the connections. I don't know how far back I would trace the vascular roots. All right, and that's really what they do. They got cirrhosis, derivative coming at you. Hypersplenism, I already told you, classic is thrombocytopenia, but any cell line can be affected. Don't get thrown off by that. And that's that. That's portal circulation. That's everything you need to know.
Take a moment to understand this question, and we'll proceed to discuss it momentarily. All right, what do we have here? A middle-aged fella vomiting blood. That's nonspecific, doesn't tell us the cause. He has an O2 saturation of 92%. 92% is not normal. Below 95% we consider hypoxemia. However, his PaO2 at 92% is probably around 70, and that is insufficient to drive erythropoietin. That is, the kidney is not perceiving this as a hypoxic state. So 92% would not drive erythropoietin production. He has a palpable spleen. So next we come to the hematocrit, 59%, which is elevated, and that causes reflex back to the 92%. That elevated hematocrit is not from hypoxemia. That is, it is not reactive erythrocytosis, which essentially is telling you that this patient probably has either polycythemia vera or elevated hematocrit from ectopic EPO production. The question goes on to describe esophageal varices. So how do you get varices? You get that from portal hypertension. Most common cause is going to be cirrhosis, but then they tell us the liver biopsy is normal. So you have a normal liver biopsy in a patient with cirrhosis and a big spleen. So how can you develop portal hypertension without involving the liver? Now let's look at the choices. So chronic alcohol consumption would be associated with cirrhotic liver, normal biopsy. Chronic hepatitis C, likewise. Next choice we have is hepatic vein thrombosis, Budd-Chiari. The problem with that is it causes a thrombosis post-hepatic, so a patient would have findings of congestive liver disease. That is, the liver would be enlarged and tender with abnormal liver chemistries. None of that information was given here. So hepatic vein thrombosis could not explain this presentation. Hepatocellular carcinoma is excluded because of normal biopsy, and gastric ulcer has nothing to do with this presentation. The correct answer is portal vein thrombosis. As discussed, you have a clot in the prehepatic location, which can give signs and symptoms of portal hypertension, but the liver is uninvolved. So the relevance of this case is to reinforce the clinical approach to a patient with portal hypertension. The portal hypertension was manifested by varices and splenomegaly, but our approach was post-hepatic, which would give liver involvement, hepatic, which essentially reflects on cirrhosis, or your other choice is prehepatic, and you're going to put a thrombosis either in the portal vein or splenic vein for that matter to produce a situation that was as was seen in this case. The final relevant feature here is coming back to that hematocrit of 59%. The 59% in this case reflected polycythemia vera, which will be a recurrent theme as the thrombophilic conditions they'll repeatedly come back to when they want to set the patient up for a thrombotic complication. And that concludes this discussion of the portal circulation and derivatives for the USMLE Step 1 exam. If you have any questions or concerns, please email me at 12DaysinMarch. Thank you.